Welcome to this week's Echo Diabetes in the Time of COVID-19 webinar session. I'm Dr. Nick Kutcher's Program Director of Echo Diabetes and a pediatric endocrinologist. Thank you all for joining, and good afternoon, good morning, good evening. We're grateful for the unrestricted educational grants that we received from Novo Nordisk and Pfizer Inc. to make this program possible. Our goal is to address the urgent needs of patients with type 1 and type 2 diabetes who require complex diabetes treatment in the time of COVID-19 and beyond. We want to empower primary care providers and clinics to safely and effectively manage underserved patients who do not have access to routine specialty care. Even before the COVID-19 pandemic, outcomes for patients with diabetes were suboptimal. Data from 191 million patients enrolled in health plans that report HEDIS results to the National Committee of Quality Assurance illustrates system failure for patients with diabetes. In 2018, less than 1/3 of patients with type 1 and type 2 diabetes had A1C targets at 7% or less. And even more concerning is that 30 to 40% of patients had A1Cs greater than 9%. We must recognize that outcomes do not reflect patient noncompliance, but rather system failure. Minimizing hyperglycemia is paramount to reducing diabetes patient risks and vulnerability to infection and complications, including COVID-19. Now is an opportune time to overcome therapeutic inertia and make meaningful system change so that patients are able to achieve glycemic goal. We are living in unprecedented times with COVID-19, but systemic racism and health inequalities have been endemic to the U.S. COVID-19 is making these injustices more clear. We must come together as a medical community and change our practice. We must act. When the mortality rate from COVID-19 in Black Americans is at least 2 times, if not 5 times as high as mortality for whites, we must act. When marked racial disparities in diabetes management exists, and prior to COVID-19, we must act. When Black Americans with diabetes with equivalent socioeconomic status as white Americans are less likely to be prescribed intensive insulin management regimens and diabetes technology proven to improve diabetes outcomes, we must act. We must act and recognize systemic racism and implicit bias that are continuing to occur within our medical community and practice. Our leadership team and faculty are committed to promoting health equity through our program and combating systemic racism in the U.S. We are committed to action. While we had expected health disparities to be a theme throughout the series, we also have an upcoming didactic session I want to call your attention to on July 22nd that will be presented by our faculty member, Dr. Ashby Walker, medical sociologist and my close colleague who directs the Echo Diabetes Program and Health Equity Initiative at the University of Florida Diabetes Institute. In the meantime, on behalf of the Echo Diabetes team, I encourage you to start to address systemic racism and implicit bias that is occurring in our practices. Here at Stanford, we're partnering with Project Echo and other sites across the United States on this series. Project Echo is a globally recognized hub and spoke outreach model developed at the University of New Mexico to reduce disparities and improve healthcare outcomes in patients who otherwise lack routine specialty care. Zoom-based clinics led by a multidisciplinary faculty from academic medical centers and community organizations provide providers with education, case-based learning, and expertise that they need to treat patients within their own community. Our presentation agenda will be a lecture followed by submitted case presentations from the community, and we'll then address some of the pre-submitted questions our audience members submitted during registration. To the topic or the presentation, please use the chat box for communicating amongst our attendees and sharing resources and best practices. We will try our best to address all of your questions submitted through the registration and chat. However, if we're unable to, please register for a future session and submit your questions again. This webinar is being recorded, and the lecture portion of this webinar will be available in a week on our website. The case presentation from today will not be included on the on-demand webinar. Our web development team is working to build a resource library on our COVID-19 website where session materials will be found. After the webinar ends, you will be emailed an evaluation that will enable you to claim continuing education credits. We have an exciting series yet to come with excellent and relevant topics. As a reminder, you and other learners are welcome to drop in for any one of these sessions or more. We are fortunate to have a national faculty team from over 12 ECHO programs, organizations around the country. I would now like to introduce them. I'm going to stop sharing my screen, and I will introduce them by state, and starting with California. Linda.
Hello, everyone. This is Linda there. I am the Director of Education for this program, and I have had type 1 diabetes for 49 years. Welcome.
Marissa.
Hi, my name is Marissa, and I'm a nurse and a diabetes educator, and I've had type 1 diabetes for 30 years, and I am the program manager.
Christine.
Hi, I'm Christine. I'm the program coordinator.
And now moving on to our faculty at Stanford, Marina.
Hi, I'm Marina Bassina, adult endocrinology.
And Magdalena.
Oh,
I think you're muted. There you go. Okay, we'll come back. And Jessie.
Hi, I'm Jessie Wong. I'm a diabetes psychologist at Stanford University.
And Rayhan.
Hey there, guys. Rayhan, med-peds endocrinologist, and had type 1 for 30 years.
And also in California, Jay.
Hi, everybody. Jay Schubert, primary care diabetologist at Torrey University, California. I'm glad you're here.
And to Florida, Eleni.
Hi, I'm Eleni Sheehan. I'm a family nurse practitioner and diabetes educator, and I also live with type 1 diabetes.
And also in Florida, Ashby.
Hi, everyone. I'm Ashby Walker. I'm a medical sociologist here at the University of Florida.
And over to Hawaii, Dan.
Hello, I'm Dan Saltman. I'm a primary care internist working in community health centers.
All right, I think we're having some audio issues, Dan. Now we'll move to Louisiana, Dragana.
Hi, everyone. I'm Dragana Lovre, Tulane University in New Orleans, Louisiana, and I'm an adult endocrinologist.
And to Maine, Irwin.
I'm Erwin Brodsky. I'm an adult endocrinologist at the Endocrinology and Diabetes Center at Maine Medical Center and an adjunct scientist at Maine Medical Center Research Institute.
And to Massachusetts, Samar.
Hi everyone, I'm Summer. I'm an adult endocrinologist and I work at the Jolson Diabetes Center here in Boston.
And to Nebraska, Leslie.
Hi, Leslie Island, adult endocrinologist at UNMC in Omaha, Nebraska, and I also have type 1 diabetes.
And to New Jersey, Mary.
Hi, everyone. I'm Mary Bridgman. I'm a clinical professor at the School of Pharmacy at Rutgers University and a pharmacist at Robert Wood Johnson University Hospital.
And to the ECHO Institute in New Mexico.
Hey, Matt Bichonville. I'm an adult endocrinologist at the University of New Mexico and ECHO Institute. Thank you.
And to New York, Marissa.
Hi, I'm Marissa Desimone. I'm an adult endocrinologist at SUNY Upstate in Syracuse, New York.
And to Washington, D.C., Nicole.
Hello, yes, my name is Nicole Earhart. I'm an adult endocrinologist at the George Washington University. I'm also the champion of the Diabetes Echo here in the DC community.
Great, thank you, everyone. And just a reminder, all our faculty are members and part of ECHO programs around the country. If you're interested in more involvement in ECHO, please feel free to reach out to them and learn more information on their program. It's now my pleasure to introduce Eleni Sheehan. She's been caring for patients with diabetes at the University of Florida Endocrinology Outpatient Clinics for more than 5 years in both the pediatric and adult endocrinology divisions. She serves as research coordinator for the Type 1 Diabetes Exchange, the Pediatric Diabetes Consortium, and HEDIS studies. She received her MS in nursing degree from UF, her BS in nursing from UF, and holds a Master of Arts degree in communication from the University of South Florida. Eleni left a successful career in marketing and development to pursue her passion, caring for people with diabetes. Diagnosed with type 1 diabetes when she was 9 years old, Eleni brings a unique compassion perspective to patient care. She serves on the JDRF North Florida Board of the Directors, volunteer advisor for the UF College Diabetes Network, and volunteer RN for the Florida Diabetes Camp. It's a pleasure to introduce Eleni today, and I'm going to pass off my share screen to Eleni to bring up her presentation. And just a reminder, if you have any questions during the presentation, please feel free to type into the Q&A box, and our faculty will respond to those questions, and then we'll save some time at the end to address live questions as well. Eleni?
Thank you, Nick. I am so honored to be a part of this amazing group and excited to share some information with everyone today. So we're going to talk about COVID-19 and sick day management for people with diabetes. And at the conclusion of this activity, you should be able to counsel your patients with diabetes on sick day management within the context of COVID-19, adjust insulin and other medications based on sick day needs, advise patients on sick day protocols and what they should keep at home. And I have nothing to disclose, and I'm just going to begin with a summary of some key guidance for your patients with diabetes. So really we want to emphasize prevention, reducing the exposure to the coronavirus, and you can do that by following the current Centers for Disease Control guidelines and local recommendations in your area. Also want to help reduce the risk of severe illness, so improve baseline health status, healthy diet, exercise, sleep, stress reduction, all of those things are so important. Also manage blood glucose levels as the best as you can, and prepare in advance of illness just in case you might get sick. Go ahead and create a sick day management plan. And as providers, we can help ensure that our patients have adequate insulin, other medications, and diabetes supplies. So I'm going to talk briefly about risks associated with COVID-19 for our patients with diabetes, but I just want to point out that next Wednesday, Dr. Kennedy is going to address the identifying high-risk diabetes patients for COVID-19 triage. So be sure to register and tune in next week for that talk. But when we look at the risk for people with diabetes for contracting the novel coronavirus, there's currently limited data on this separate risk for diabetes. So the expert opinion is really that having a diagnosis of diabetes doesn't independently increase the risk of exposure. Healthy young people with diabetes whose blood glucose levels are within their target range, who have no comorbidities, they don't appear to be a greater risk of infection from COVID-19 than their peers who don't have diabetes. And for folks with type 1 diabetes, understand that having an autoimmune disorder does not mean that they are immune compromised. So in terms of severity, I'm going to just talk very briefly. The United States Centers for Disease Control and Prevention states that individuals with diabetes are at higher risk for severe illness with coronavirus and poorer health outcomes. So investigators are still working on determining why, and new data is emerging rapidly. But for now, it does seem that for an otherwise healthy young person with no comorbidities, having a diagnosis of diabetes does not appear to independently increase the risk of more severe illness related to COVID-19. However, diabetes management becomes much more complicated in the setting of illness. And for people with type 1 diabetes and COVID-19 infection, there is an increased risk for diabetic ketoacidosis, or DKA. There was a study published in Diabetes Care last week that reported preliminary data on 64 people with type 1 diabetes and confirmed or suspected COVID-19, and nearly 1/3 of those people experienced DKA. Many other studies have been coming out recently that demonstrate a greater risk for severity of illness with diabetes, and they suggest that this risk increases with hyperglycemia, older age, and comorbidities, including obesity, microvascular and macrovascular complications, and obstructive sleep apnea. Fortunately, the pediatric population has shown less severe outcomes than in adults. So the question then is, what can we as providers do to help mitigate this risk for our patients with diabetes? And while data is continuing to emerge and help inform our treatment decisions, here's what we know for sure. Managing diabetes during illness is challenging. We want to emphasize preventing illness, and we want to help our patients prepare in case they do get sick by creating diabetes management plans for sick days, ensuring that they have enough medications and diabetes supplies, and providing them with support. So the CDC recommendations for prevention of COVID-19 infection in people with diabetes is not much different than recommendations for the general population. And in the US, we've all likely heard these recommendations that are listed here. Minimize physical interaction with others, maintain strict personal hygiene, avoid touching face and unwashed hands, routinely disinfect high-touch surfaces in the home, avoid any non-essential travel, convert healthcare visits to telemedicine whenever possible, and take extra precautions when out in public by wearing a cloth mask or face covering and maintaining a distance of 6 feet from other people. And it's really important as states are opening up, and it's important to remind our patients with diabetes to really remain vigilant in taking these precautions. Briefly, to look at the effects of illness on diabetes. So some illnesses, especially those associated with fever, like COVID-19, raise blood glucose levels because of higher levels of stress hormones, which can lead to increased insulin resistance. For people treated with insulin, the illness often increases ketone body production due to inadequate insulin levels and the counter-regulatory hormone response. And then hypoglycemia can also result either from reduced food intake or excess insulin administration. But what's important to note is that insulin needs are they're highly variable from one person to another, and also from one illness to the next. So it's important to examine each person's needs individually and really closely monitor the response to treatment. So the International Society of Pediatric and Adolescent Diabetes, hereinafter referred to as ISPAD, recommends these 5 sick day diabetes management principles. Sick day guidelines, including insulin adjustments, should be taught soon after a diagnosis of diabetes and then reviewed at least annually with patients and their family members. More frequent blood glucose and ketone monitoring is needed. Do not stop insulin or other diabetes medications. Monitor and maintain hydration with adequate salt and water balance, and treat any underlying precipitating illness. So it's a common mistake for people to stop taking insulin completely because they're sick and they're not eating. I hear this from my patients all the time. Well, I stopped taking my insulin because I wasn't eating. Well, what this does is actually increase the risk of DKA and more severe illness. So even in the fasting state, some insulin is required for basal metabolic needs, and those needs may go up during an acute illness. And more frequent monitoring of blood glucose and ketones is required to help guide the insulin doses. And the insulin dose, it may need to be increased or decreased to maintain the glucose metabolism, but it really should never be stopped. So a sick day diabetes management plan. Let's help our patients plan ahead in case they do become ill. So what does this involve? should include medication instructions, sick day meal plan, how often to check blood glucose, when to check for ketones, when to call the provider's number. And here are just some excellent patient handouts. They were prepared by the Association of Diabetes Care and Education Specialists, and also there's one by the American Diabetes Association, and you can download those by accessing those links right there. So for sick day management, it's important. The hydration recommendations are 8 ounces of sugar-free and caffeine-free liquids every hour. If not able to hold down that volume of liquid, then frequent sips of liquid are appropriate. And sugar-free popsicles and sugar-free gelatin are some good alternate choices that also provide hydration. Encourage your patients to try to follow a regular meal plan, but if they're not able to eat, it's okay to substitute a regular carbohydrate intake with liquids and fluids that have some sodium and other electrolytes in them may be helpful, such as regular soda, gelatin, popsicles, Gatorade or Pedialyte, sherbet, and soup. And then more frequent monitoring is really so important. Blood glucose, check at least every 4 hours or use a continuous glucose monitoring system. And then ketones, either urine or blood, check every 4 hours. So ketone monitoring is especially important for patients with type 1 and insulin-treated diabetes. General guidelines are to check for urine or blood ketones anytime the blood glucose is greater than 300 if you're on injections, or 240 if you're on a pump, but also to check for ketones when you're ill or vomiting. And then also for symptoms of ketones. So those symptoms can include frequent urination, excess thirst, nausea and or vomiting, stomach pain, flushed skin, weakness, rapid heart rate, shortness of breath, deep or troubled breathing, or confusion. And we're going to talk about the deep or troubled breathing in a few slides from now. And then these are just pictures of the 2 types of ketone testing that's available in the United States. So the urine test strips are available over the counter or by prescription. They're typically more affordable than the blood ketone test strips. The blood ketone testing is preferred, but the cost may be prohibitive. They are available over the counter or by prescription also, but tend to be more expensive, and a number of insurance companies do not cover those. So briefly, I'm going to talk about additional insulin for sick day management. So insulin dose adjustment is usually required during illness, and this is additional doses of rapid acting insulin, which is preferred, or short acting insulin are required to reduce the blood glucose, turn off ketogenesis, and prevent the progression to ketoacidosis and hospital admission. So the additional dose of insulin is calculated as a percentage of the total of both the rapid acting and the long or intermediate acting insulins for the day. And it's defined as the total daily dose. Many of your patients may be on a fixed dose bolus regimen. For example, 10 units of insulin aspart before each meal, combined with a once daily fixed dose of a basal insulin, or they may be on fixed doses of a mixed insulin, for example, 75-25, 20 units twice a day. When folks are sick, they may need additional insulin, and it's very helpful to provide a correction scale that they could administer when their blood glucose levels are above target range and or when ketones are present, and they can use this when they're not eating. So this is one example of one method that can be used to calculate a patient's correction dose. So it's called the rule of 1800 for calculating the correction factor, and it's 1800 divided by the total daily dose equals the milligram per deciliter drop in blood glucose. So for example, let's say that your patient takes insulin degludec 30 units once a day and insulin aspart 10 units 3 times a day before meals. their total daily insulin dose then is 60 units of insulin. So if we plug that into our formula, 1800 divided by 60 is going to equal 30 milligrams per deciliter drop in blood glucose. So 30 is your correction, or sometimes it's called sensitivity. It's that factor. So continuing our example. Okay, so that's great. So what does your patient do? How do they know how much insulin to take? Well, there's a formula that you can use and they can use. So it takes the current blood glucose minus the target blood glucose divided by the correction factor, and it equals the number of units to take. Sounds fairly complicated, but it's really actually quite simple, and most folks catch on pretty quick. So let's say that my blood sugar is 330, and my target blood sugar level is 130. And my correction factor, based on the previous slide, is 30. So we would call that correction scale 1 unit of insulin for every 30 points over 30. And you'll sometimes see it abbreviated as I've put it in the parentheses 1:30 greater than 130. So let's plug this into our formula. Blood glucose level 330 minus our target blood glucose, which is 130, equals 200. 200 divided by 30, the correction factor, equals 6.67. So this means that I need 7 units of rapid-acting insulin to bring my blood sugar down to a target of 130. So that's great, but when you're sick and you have ketones, it doesn't always work. So often you need additional insulin. So ISPAD has compiled some wonderful algorithms. They're available online, but this is actually, even though the slide looks really busy, it's a condensed version of their guidelines. So if folks are sick and they have hyperglycemia, if the ketones are negative, just give the ordinary bolus dose for their carbohydrates and their correction plus fluids. If the ketones are small or mild, you want to add an additional 5 to 10% of the total daily dose, or you can give 110% of the calculated correction bolus plus fluids plus insulin. Ketones are medium or large, add 10 to 20% of the total daily dose, or give 110% of the calculated correction bolus plus fluids plus insulin to cover the carbohydrates if they're eating. And then if the ketones are extra large, add 20% total daily dose, or give 120% of the calculated correction bolus plus fluids plus insulin to cover the carbohydrates if they're eating. But note that there's a very high risk of DKA when ketones are extra large, and you may consider transferring that person to the emergency department. Monitoring, again, is so important. Monitor the blood glucose and the ketones every 2 hours, and repeat additional insulin according to these guidelines if they're needed every 2 to 4 hours. And you may also need to increase the basal insulin doses during illness. Again, continuous monitoring or more frequent monitoring to adjust insulin doses based on that. So, as we mentioned, you can also have hypoglycemia when you're sick. So it's important to remember that ketones can occur even when the blood glucose levels are normal or when they're below the normal range, especially in the setting of illness. So hypoglycemia with hyperketonemia requires administration of insulin along with carbohydrate intake. And this is what we call the need to feed the ketones with insulin and carbs. If folks can't keep food down, liquid carbohydrates are okay. This is the time someone can drink regular soda or regular juice, because and along with taking that insulin. So it's important to check ketones along with blood glucose as a guide to determine if starvation ketosis is occurring. And then for basically, do not stop the basal insulin. That's really important. You may need to make a reduction depending on how small or large the ketones, but it's really important to not stop the insulin because adequate basal insulin delivery is necessary to prevent hyperketonemia due to insulin deficiency. So continue the basal insulin, may need to reduce it. For small ketones, give the ordinary bolus insulin for the carbohydrates and or for correction. But, and if there's moderate to large ketones, add an additional 5% of the total daily dose to the ordinary bolus. And again, check for blood glucose and ketones every 2 hours. And this algorithm is available on ISPAD, and there's a link down there to it. So to treat hypoglycemia, mild to moderate, when blood glucose is less than 70, there's what we call the rule of 15. And basically it's eat or drink 15 grams of carbs, wait 15 minutes. I personally have to set a timer, wait 15 minutes, then recheck the blood sugar. If it's still less than 70, you repeat those steps 1 through 4. You can continue repeating this until the blood glucose is above 70. And then here are just some examples of some 15-gram carb snacks that are effective at raising the blood sugar level quickly. And then glucagon, make sure that your patients, especially those with type 1, have an up-to-date prescription on hand. This is treatment for severe hypoglycemia. There's exciting stuff coming out. We actually have a couple of new formulations. So these red and orange kits are the traditional formulation that needs to be mixed prior to administration, but we now have an intranasal glucagon and a pre-mixed and pre-filled syringe that's available on the market. So just a note of some special situations that may increase the risk of DKA. The use of SGLT2 inhibitors may increase the risk of DKA. So it's recommended that to stop them if the patient is vomiting or if there's any dehydration occurring, and to avoid the use in hospitalized patients. Low carbohydrate diets and disordered eating can also increase the risk of DKA. So in terms of sick day management, when should you tell your patients to call you? General recommendations are that if they've been sick for 2 or more days then with no improvement, to call you. If they're vomiting or diarrhea for more than 6 hours, moderate to large ketones, symptoms of DKA or dehydration, really if they don't know what to do, they should call you. You may choose to direct your patients to an emergency department if they are vomiting and if they have moderate to large urine or blood ketones. And the goal here is really to intervene before emergency services are needed. And then just a note about Kussmaul breathing. So Kussmaul breathing, it's deep and labored breathing pattern that's often associated with severe metabolic acidosis that's often seen with DKA. It's a form of hyperventilation. And in this time of COVID-19 hyper-awareness, if your patients do report this type of breathing or if you observe it, be sure to consider the possibility of DKA. So assess for that, ask questions. Are they experiencing frequent urination, excess thirst, any weight loss, decreased energy, vomiting? Check for ketones, check what their blood sugar level is, and just make sure that you rule that out before you treat for a respiratory illness. So we want to help our patients make sure that they have enough medication and diabetes supplies on hand. In the United States, these supply companies do not predict a shortage, but go ahead and update your patients' prescriptions, ensure they have at least a 30-day supply on hand. Consider a 90-day supply for all prescriptions if available. And refill restrictions have been lifted for the certain essential medications like insulin, and you are able to refill those medications before the typical 30-day waiting period. If you're able to send it to the prescription to a mail order pharmacy, that is great. And also encourage your patients to ask their local pharmacy about delivery options. Many pharmacies are now offering free local delivery. It's also something to just keep in mind that if your patient is unable to get their insulin prescription refilled, something happens, there are in the United States insulins available over the counter at Walmart. These are NPH and regular and pre-mixed insulins. They're approximately $25 a vial. And then also if your patients, if they've lost their insurance or are having difficulties, lower cost oral medications typically are metformin and sulfonylureas, and you may want to help them adjust their medication plan so that they can afford to take their medications. There's just a number here. I believe Nick showed this on a previous Wednesday call, but I wanted to share it again. There's an emergency supplies hotline, 314-INSULIN, and you can call and get resources to help folks who may need an emergency supply. And then also just go over with your patients, make sure that they have the adequate supplies, meter, strips, and lances. Even if they're using a CGM, they want to have these as a backup. Ketone test strips, glucagon, syringes, pen needles, sugary drinks for treating lows, broth or soup, just in case they can't eat regular foods, and then also staples, including frozen foods and canned goods. So I'm going to close with some key points for your patients that you can share with them. Encourage them to continue taking their medications and do not stop insulin or change doses without first talking to the provider. And also, do not delay getting emergency care for your diabetes or other underlying conditions because of COVID-19. Know that emergency departments have infection prevention plans in place. And if they need care, they need emergency care, they should go. And also encourage them to call you if they have any concerns about their medical conditions, or if they get sick or think they may have COVID-19. And always, if they need emergency help, don't hesitate to call 911. And then additionally, provide support. This is challenging for all of us, and mental health resources should be available to patients who are having difficulty dealing with the pandemic. And it's also just really important to educate and empower our patients to do the best they can to protect themselves from getting the infection, and then also to prepare in advance just in case they do become ill, and to manage their diabetes as best as they can to achieve the best outcomes possible. So I will say references will be online, and thank you so much for listening, for your time, and I will stop sharing and we'll open it up to any questions.
Thank you so much, Eleni. Just as a reminder, you can type in questions into the Q&A box, and you can see questions that have been answered. Coming in, there were some lots of questions on calculating the correction dose. And so there's the 1800 rule and the 1500 rule. So dividing your total daily dose by that for clarifications. And these slides will be made available on our website, and so you'll be able to see those equations and to recap them. Any other faculty members answer some questions you want to share with the group?
I just want to highlight a question from somebody who asked, aren't people with type 1 considered immune compromised or immune suppressed? So I just, and thus naturally at greater risk. So there is no evidence that people who have diabetes are at greater risk for having an infection, even COVID. But if they do get an infection, COVID or otherwise, there are inherent issues with the immune system that may make it more difficult to clear the infection. So risk of infection isn't higher, but if they do get an infection, it may be a little bit more severe due to the inherent issues in the immune system. So there's a difference between the two.
There was a question about whether there are phone apps or that can be used to do any of those calculations that were for insulin adjustments.
I don't know if that question was audible for everyone, but there was a question about whether there are phone apps to help you do calculations for insulin dosing. I think I heard that correctly, Dan. I don't know. Eleni or Nick, are you aware of resources?
Yes, so there are apps that help you calculate it, and where you can also link in to your meter on blood sugar monitoring. There's also something called the InPen, which calculates how much insulin you kind of have on board and gives a dose recommendation. So that's probably the most robust right now for people who are using insulin pens. And we can type in the chat box some additional resources as well for that. Great question. And there was also a couple more questions coming in on more individualized management, so in children and in adults. So once again, just to reinforce from what Eleni said, is that we have the general principles, and then all of those general principles, we want to then individualize it for either the pediatric patient or the adult patient. And we can take some time for some additional questions if you want to type them in. And once again, the slides from today's lecture will be available on our demand website later in the week.
There was a question that was typed in about if there are differences in the COVID outcomes between type 1 and type 2 diabetes.
So this is Jay Schubrook. I think this is an important question. I think in type 2 diabetes, it's a much more complex disease. It has many metabolic conformations and constituencies. So I think when you have type 2, your metabolic control has a big impact on how you experience the illness. So what's your blood pressure? What's your lipid control? Are you on anti-inflammatories? So there is a difference, but even in the difference, control has a lot to do with how you do with the response.
I would just like to add to that, you know, this is such a new and emerging area where all of us are still learning, and there are currently registries in place where people are collecting information on patients with both type 1 and type 2 diabetes so that we can look at outcomes as we really try to learn and understand how this disease affects patients with diabetes compared to the general population. So I think there's more information to come on that question.
Marissa, could you put those registries in the chat box so we can have them as on our list of resources, please?
I will get the information.
Okay, no worries.
Great. And then so if there's still questions related to sick day management, Eleni and other faculties, we can type in and address that. But right now we will transition over to our community case presentation. Usually at the end, we try to at least present one submitted question and answer. It looks like we might go 3 or 4 minutes over. So for those of you who want to stay on for this question, please feel free to do so. And so I think Marissa was going to address this. There's a question: what are realistic A1C goals when you're getting A1Cs during shelter-in-place restrictions for patients not checking their own glucose, any other measures if not permitted to get labs?
Oh, that was me, actually. This is Leslie.
Oh, great. Thanks, Leslie.
So in summary, my answer at the end was going to be maybe, probably not, in terms of if you should get the A1C. So are A1C goals unchanged? No, because glycemic control may play a role in your severity of illness. So A1C goals, I think, stay the same. When should we get an A1C in the time of COVID? I don't know for sure. There's really no good guidelines. There's some guidance available from recent commentaries, and with everything, it's a matter of weighing risks and benefits. And in my opinion, it really depends on how well or how often your patient is monitoring their glucose as an outpatient. So on my next slide, I broke it down to, you know, do you send your patient to the lab? Do you not? I would consider not getting an A1C if they're on a CGM, right? You can use, there's so much great data that you can use to change their insulin regimen with, and it's more important than the A1C in my opinion in order to make, you know, tiny tweaks to their regimen. I also am not getting A1Cs in my patients who provide me frequent point of care data, because again, I'm going to change the regimen based on that data, not necessarily their A1C. And I don't like to get a lab if it's not going to change my management. I would consider getting an A1C if they don't have any data for you, if they're not routinely checking point of cares, they're not on a CGM, and if their rates of COVID in their area are relatively low. Some labs have set up kind of outside safe labs for people just to kind of walk in and get a quick lab draw and walk out. But if the lab is down a long hallway and shares a waiting room with the urgent respiratory clinic, then probably not a good idea. Also, I've been asking patients to batch lab, so maybe my A1C is not a priority, but if they're getting tumor markers with their oncologist within the next month, or an INR for their Coumadin check, or they're meeting with their nephrologist and their GFR has been fluctuating, I've tried to really just batch as many labs as possible together. If they're not checking any data at home, you can prescribe them a glucometer. You can ask them to start checking sugars and review what their goals should be. There are also some home A1C kits on the market. I have limited to no experience with this, but I do know that Bayer makes one called A1C Now, and it is CLIA waived, so the accuracy must be pretty decent. And that could be a really good option in patients who are scared to go to the lab, or you don't want them to go through that risk, but an A1C is kind of the information that you're looking for to keep them safe.